Hello everyone, welcome back to CMME Easy, and I hope you all are doing very well. Before we begin, let me remind my dear students that the contents of this channel are only to supplement your knowledge, not to replace the regular online and offline classes in your institution. So please attend your classes and do not miss them. Also, if you like our contents, please subscribe to our YouTube channel, like the videos and share these videos with your friends, with your batchmates, with your juniors. Also, if you are a teacher, then with your students. Please follow our Facebook page and the link will be given in the description. Previously, we had a detailed discussion on malaria. Today, we shall start another mosquito-borne disease, that is dengue. Dengue is known to be a major public health problem all over the world. And this is common in tropical and subtropical countries all over. If you look at the data that is available to us, as of 23rd November 2022, we have about 3.6 million cases and 3,380 deaths all over the world. Majority of these cases were reported from Brazil, Vietnam, Philippines, India and Indonesia. Majority of the deaths from dengue were reported from Brazil, Indonesia, Philippines, Bangladesh and Vietnam. If we are looking at the data for India in the year 2022 till 31st of October, 1,10,473 cases and 86 deaths were reported. All these data have been taken from European Center for Disease Prevention and Control. According to WHO data, there had been an 8-fold increase in the number of cases reported in last 2 decades. We had about 5 lakh cases in the year 2000, which increased to 2.4 million in 2010, and that increased to 5.2 million in 2019. Similarly, the number of deaths also increased. So in the year 2000, we had 960 deaths all over the world, whereas in 2015, the number of deaths increased to 4,032. And all these deaths mostly occurred in the younger age group. Surprisingly, the number of cases as well as the number of deaths from dengue decreased during the year 2020 and 2021. The problem here is all these records were incomplete, and that was probably because of the COVID-19 pandemic that actually disturbed or hampered the reporting system all over the world, and because of that we had so many under-reporting of dengue cases and deaths. We know dengue is a viral disease. This dengue virus is a single-stranded RNA virus, and there are 4 distinct serotypes: DEN 1, DEN 2, DEN 3 and DEN 4. If a person is infected with any particular serotype, he is immune to that particular serotype for the rest of his life. Although all these 4 serotypes are antigenically similar, so they provide some cross protection against each other, but the duration of the cross protection is not lifelong, it is for only a few months. Secondary infection with dengue serotype 2, that is DEN 2, or multiple infection with different serotypes can lead to severe form of dengue, hemorrhagic fever or dengue shock syndrome. Vector is the Aedes mosquito, the female Aedes mosquito. We have Aedes aegypti and Aedes albopictus. Especially the Aedes aegypti is highly domesticated, that means it remains inside the house. Strongly anthropophilic means it feeds on the human blood, and nervous feeder, that means it bites a person multiple times to complete its blood meal. Once the mosquito becomes infective, it remains so for life. So until we kill that mosquito, it will keep on transmitting the virus to the person it is biting. The genital tract of the mosquito gets infected, and trans-ovarian transmission of the dengue virus occurs when the virus enters fully developed eggs at the time of oviposition. So when a mosquito takes the blood meal, it also transfers the virus by vertical transmission to the eggs, and these eggs also will have the virus when they are hatched into mosquitoes. Environmental factors include rainfall, especially the heavy rainfall that leads to artificial collection of water. That means storage or accumulation of water in in discarded utensils, plastic buckets, coconut shells, tubes, rubbers, etc. around our houses, and this artificial collection of water acts as the potential breeding place for mosquito, the Aedes mosquito. Also, because of the rainfall, the temperature fluctuates between 16 to 30 degrees Celsius and the relative humidity is quite high, 60 to 80%, and this temperature and humidity favors the survival of the mosquito, that is the vector of the disease. Now coming to the clinical feature, that is the main discussion for today's video. The infection can be asymptomatic in some cases, and it may be undifferentiated febrile illness, also known as viral syndrome. Or we can have classical dengue fever, we can have dengue hemorrhagic fever, also dengue shock syndrome. If you look at this classification here, so dengue virus infection can be asymptomatic or symptomatic. If it is symptomatic, it can be undifferentiated fever or dengue fever with or without hemorrhage. Then we can have dengue hemorrhagic fever, and we have 4 grades, grade 1, 2, 3 and 4 of dengue hemorrhagic fever. Remember, this dengue fever syndrome with or without hemorrhage is known as classical dengue fever. Grade 1 and grade 2 of dengue hemorrhagic fever is known as dengue hemorrhagic fever, whereas the DHF grade 3 and grade 4 are known as dengue shock syndrome. We shall learn about the details about how to classify these grades in our future slides. First, we shall talk about the undifferentiated fever. So, any person, an infant, children or adult who is infected with dengue virus for the very first time, that is known as the primary infection, may develop fever that is indistinguishable from other viral infection. There may or may not be maculopapular rash accompanying the fever, and may appear during the defervescence. That means when the temperature is going down, the fever is going off. Upper respiratory tract and gastrointestinal symptoms are quite common. There can be respiratory distress, cough or cold, as well as diarrhea, abdominal pain, etc. may be there. Next is the classical dengue fever. Onset is acute. There can be chills and the temperature is quite high, 39 to 40 degrees Celsius. There can be intense headache, muscle or joint pain, so there can be myalgia, arthralgia, etc. And movement is quite difficult because of this muscle pain and joint pain. Within 24 hours, the person may develop retroorbital pain, and the person will complain that he is having pain, particularly during the eye movements. Also, eye pressure and photophobia may develop. Other common symptoms may include extreme weakness, anorexia, constipation, altered taste sensation, colic abdominal pain, abdominal tenderness, dragging pain in inguinal region, sore throat and general depression. So these are the clinical features. So the person is having eye pain, so maybe there is retroorbital pain, there will be fever, rise of temperature up to 40 degrees Celsius, headache, abdominal symptoms like nausea, vomiting, maculopapular rash may be present, there can be arthralgia, joint pain, there can be bone pain, muscle pain or myalgia, etc. All this may be present. Then comes the dengue hemorrhagic fever. It is the severe form of dengue fever, and the course of dengue fever, dengue hemorrhagic fever, it is divided into 3 phases: the febrile phase, the critical phase and recovery phase. First, the febrile phase. Of course, as the name suggests, there is fever. There is abrupt or sudden onset of high fever, 40 to 41 degrees Celsius, following incubation period of 4 to 6 days. This may be associated with facial flushing, headache, anorexia, epigastric discomfort, vomiting, and general abdominal pain. Sometimes in infants there can be febrile convulsion. Next comes the critical phase. We have to remember that every person who is in febrile phase may or may not go into the critical phase. Some person from the febrile phase go directly into the recovery phase. Okay, what about critical phase? Around the time of defervescence, so when the temperature is going down, as if the fever is going away, the person will actually start feeling better. When the temperature drops to 37.5 to 38 degrees Celsius or even less, usually that is 3 to 7 days after the illness, there is increase in capillary permeability in parallel with increasing hematocrit level, and this is the marker of the beginning of critical phase. Progressive leukopenia with rapid decrease in platelet count usually precedes the plasma leakage. So if we simplify the whole thing that I just said, the person will have fever in its febrile phase that we discussed here. After that, the temperature is going down. This is when first there is leukopenia, the WBC count goes low, as well as there is drop in the platelet count. This is followed by increased capillary permeability, plasma leakage, and there is increase in hematocrit value. So this is when the critical phase has already started. Now at this point, without an increase in capillary permeability will improve. So if a person does not develop increased capillary permeability, he will not be in the critical phase. His condition will improve. Now the degree of plasma leakage may vary. Of course, there can be pleural effusion, mostly right sided, ascites, gallbladder edema, etc. That is why chest x-ray and abdominal ultrasound are very useful tools for diagnosis. We have to conduct chest x-ray, abdominal USG to diagnose if there is any pleural effusion or ascites or gallbladder edema. Shock occurs when a critical volume of plasma is lost through plasma leakage. So due to increased capillary permeability, we may lose plasma, and if we lose plasma in a huge amount, there can be shock. It is often preceded by the warning signs or danger signs, and these are the warning or danger signs. There can be bleeding in different forms: epistaxis, scanty hemoptysis, hematemesis, that means person is vomiting out blood, gum bleeding, black colored stool, excessive menstrual bleeding, dark colored urine, or hematuria. The person can feel lethargic or restlessness, and there may be sudden behavioral changes. There can be confusions, difficulty in breathing, so dyspnea may be there, or palpitation or breathlessness, etc. Persistent vomiting, that is more than 3 times a day, severe abdominal pain, enlarged or tender liver, chronic fluid accumulation in different part of the body in the form of ascites, pleural effusion, etc. Clinical fluid accumulation, I just said that. Postural hypotension because of loss of plasma in the circulation. Dizziness may be there. Pale, cold, clammy hand and feet, these are the signs of shock. Not able to drink and no urine output for 4 to 6 hours, or urine output is less than 0.5 ml per kg per hour. Rising hematocrit value more than 45%, together with rapid fall in platelet count. So these together are very important. There can be metabolic acidosis, derangement of liver kidney function test, pleural effusion, ascites, gallbladder edema on imaging. So chest x-ray or USG. So all these are danger or warning signs, and if we find any of these signs, then we may think that the person is progressing towards shock. When a person has been in prolonged shock, there can be hypoperfusion in the major organs. That may lead to the organ impairment or even organ failure. There can also be metabolic acidosis and disseminated intravascular coagulation that may again lead to severe hemorrhage, causing the hematocrit to decrease. If you remember, I said that hematocrit generally increases here also in critical phase, and also the rise of hematocrit more than 45% is a warning sign for shock. But if there is severe hemorrhage, the hematocrit may decrease. Also, there is leukopenia, progressive leukopenia in the critical phase. But again, if there is severe bleeding, the total WBC count may increase. In addition, there may be severe organ impairment such as severe hepatitis, encephalitis, or myocarditis, and or there may be severe bleeding without obvious plasma leakage or shock. Now, what happens in critical phase that we learned is there is increased capillary permeability and there is plasma leakage. Of course, that leads to hypoperfusion to the organ. In the next 48 to 72 hours, what happens is there is gradual reabsorption of this extravascular compartment fluid that we just lost because of increased capillary permeability. So, because of the reabsorption of the fluid, there is now replenishment of the circulation, and the general well-being improves, appetite returns, gastrointestinal symptoms goes away, and hemodynamically the person is now stable. Diuresis occurs, that means the person starts producing urine and there is frequent micturition. Bradycardia and electrocardiographic changes are quite common in this stage. Hematocrit stabilizes or may be even lower due to dilutional effect of the reabsorbed fluid. WBC count generally starts rising soon before the platelet count starts rising. So, it is a WBC count that starts rising first. After that, the platelet count starts rising. If we summarize all this finding in a single table, in clinical dengue, we have febrile or viremic phase, then we have critical phase and then recovery phase. The febrile phase lasts for 2 to 7 days and the symptoms include headache, myalgia, arthralgia, retroorbital pain, etc. In children, there can be anorexia and nausea, vomiting. There is progressive decrease in WBC, so leukopenia is there. Total count may be less than 5000 per cubic millimeter with mild thrombocytopenia, so platelet count may go a little bit lower. There may or may not be any hemorrhage, and there is positive tourniquet test. What is tourniquet test? That we shall learn in our future video, not in today's video. There may be dehydration and high fever leading to neurological disturbances and febrile seizure, especially in infants. Critical phase, we have warning signs between the day 3 and day 7, and we have all this list here. So, all these are the warning signs for shock. There is increased capillary permeability causing the plasma leakage, and there is rising hematocrit, which is the earliest sign of plasma leakage. Shock may occur because of plasma leakage, which in turn leads to organ hypoperfusion. There can be severe hemorrhage and organ impairment because of organ hypoperfusion. Then we have the recovery phase, which occurs due to reabsorption of the extravascular compartment fluid in the next 48 to 72 hours. The person's general well-being improve. There is aisles of white in sea of red. What is aisles of white in sea of red? I will explain in the next slide. Fluid overload may occur. Since a person in critical phase has increased capillary permeability leading to plasma leakage, the treatment during this phase is to give intravenous fluid therapy. When the person goes into the recovery phase, and if he is still on intravenous fluid therapy, along with that there is reabsorption of extravascular compartment fluid, so there is fluid overload in the circulatory system. So there is fluid overload which may lead to heart failure. So in recovery phase we have hypervolemia and there can be acute pulmonary edema. This is the rash in dengue. We have erythematous rash in the forearm, also in the back, and someone has placed his hand against the back and pressed against it, and this has caused the blanching. So blanching may be present, but remember, if the rash is present along with blanching, this is during the febrile phase. This is another example. You can see this is the back of the of a child with reddish appearance, so there is rash and there is also blanching. This is during the febrile phase. During the convalescent phase, we have this rash on the leg. Also in between the rash we have the normal skin, so normal looking or normal appearance skin is present. This is known as the white aisles in the sea of red. This is the petechial rash. In between them we have the normal colored skin. This is the white aisles in the sea of red. Remember, this particular rash is not blanchable, so we will not find any blanching during the convalescent stage. blanching is present during the febrile stage only. Now if we try to find out or try to grade the dengue fever based on the presentation, we have the classical dengue fever. So here we have fever for 2 to 7 days with 2 or more of the following. So all the symptoms may be there, signs and symptoms. There may be headache, retroorbital pain, myalgia, arthralgia, with or without leukopenia, thrombocytopenia, and no evidence of plasma leakage. We know that plasma leakage is present in the critical phase, it is not in the febrile phase. So in classical dengue we have only fever along with some of the symptoms. There may or may not be any leukopenia, thrombocytopenia, but there is definitely no plasma leakage. In DHF1 or dengue hemorrhagic fever grade 1, we have the above criteria. So all these features of dengue fever, along with that positive tourniquet test and evidence of plasma leakage. What is positive tourniquet test? Again, I told earlier, we shall discuss it in the next video. There may be thrombocytopenia with platelet count less than 1 lakh, hematocrit rise more than 20% over the baseline, or after fluid replacement the hematocrit will be 20% lower. In DHF2 we have all the features of DHF1, along with that evidence of spontaneous bleeding in skin or other organ. We may have black tarry stool, along with that epistaxis, that means bleeding from nose and gum bleeds, and there will be abdominal pain. DHF3, that is known as dengue shock syndrome, above plus circulatory failure. Because of bleeding we can have circulatory failure. We have weak rapid pulse, narrow pulse pressure less than 20 mm of mercury, hypotension, cold clammy skin, and restlessness. And in dengue hemorrhagic fever grade 4, that is also DSS, we have profound shock and undetectable blood pressure or pulse. So in classical dengue fever, only fever with some symptoms, with or without leukopenia, thrombocytopenia, but no plasma leakage. Plasma leakage present, it is DHF1. But when we have spontaneous bleeding, that is DHF2. Again, if there is any circulatory failure, we have DHF3 and DHF4. In DHF4 we have profound circulatory failure or profound shock. So this is the gradation of dengue fever based on the presentation. So today we have learned about the dengue virus, the vector for the disease, and also the environmental factor that helps in transmission of dengue in the community. But in more details we have learned about the clinical features of dengue. We have the undifferentiated fever, the classical dengue fever with some symptoms. Then we learnt about the dengue hemorrhagic fever in its febrile stage, critical stage, as well as the recovery stage. We also learned the different danger signs for development of shock in dengue, especially in the critical phase, and how we can have different rashes, the rash in the febrile stage as well as in the convalescent stage. And at last we learned the gradation of dengue fever based on the clinical presentation. So with this we conclude today's session. If you like the video, please subscribe to our channel and share this video with your batchmates, juniors and friends. We also have our Facebook page that you can follow. The link is given in the description. Take care, and we shall see you in our next video.